Welcome everyone to today's webinar, Hospital Price Transparency, a Guide to Quick Compliance. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We'll have a series of poll questions during today's webinar. You can submit your answers on your screen in the slides box. Thank you in advance for your participation. You also will find a few different engagement tools on your dashboard. Please check out our resources section and also make sure you fill out our session survey. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. Lastly, if at any time you have trouble with audio or video, please try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. At this time, it's my pleasure to introduce our two speakers. Betsy Block has more than 20 years of experience in healthcare marketing and strategic planning for community hospitals and academic medical centers. Her areas of expertise are in the development and implementation of clinical integration programs, as well as the physician alignment platforms needed for optimal performance under value-based care. She has architected solution-oriented business development strategy for value-based care and partnered with senior healthcare leaders and physicians on implementation of new models of care. James Holohan has more than 18 years of experience in healthcare leadership, strategic planning, network development, and performance improvement. His areas of expertise are working with health systems on strategy, value-based care contracts, population health, consumer-based pricing, and payment reform. Mr. Holohan began his career at Thomas Jefferson University Hospital as a physical therapist and transitioned into management roles with increased responsibility. He spent 10 years with Kindred Healthcare, the largest provider of post-acute care services in the United States, most recently as the Philadelphia market CEO. He also served as the Executive Vice President of Operations for Fox Subacute Management, Inc. With that, I'm pleased to hand the floor over to Betsy to begin the presentation. Betsy, take it away.
Welcome, everyone. Thanks for joining us. One of the things that was not mentioned in those lovely bios is how deeply involved Jim and I have been with hospitals in meeting the compliance of price transparency regulations, both from the just basic compliance part and then also understanding the strategic implications. So we're really excited to be sharing some of the insight that we've gained with you today. So let's talk a little bit about our agenda. We're going to go over sort of the history of price transparency. Why are we doing this? What's all the fuss about? We'll talk a little bit about the current regulation, which most of you are probably familiar with, so we won't spend a lot of time there. But we are going to talk about compliance, who is, who isn't, and then try to get some more insight into maybe why we're not complying or why we are. And then one of the areas that we've found has been most challenging for the clients that we're working with is the machine readable file. So we're going to go over some insights that we've gained on overcoming some of the common challenges to putting that file together. And then we're going to talk about strategic implications of this from a consumer standpoint, also from a pricing standpoint. So we hope that it's a very informative session for you. Let's go and talk about the history. Why all the fuss, right? And if you think about it, it's not just about consumers avoiding surprise billing. That's important, right? But it goes far beyond that. I think if we were only worried about that, it would be sort of almost a unicorn. It might be a passing area of interest, but this isn't a passing area of interest. And that's for several reasons. First of all, the US spends more on healthcare than any other country in the world. And I think we all know that. And we understand that it's a problem. And we've been trying to address it. The government, private payers, self-funded and insured, self-insured corporations, everyone's trying to solve this issue. And we haven't had a whole lot of success to date. So a lot of analysts have taken a look at what is the reason that we are struggling so much. And part of that reason is higher prices. So as prices, even as we've tried to contain prices have risen over time, and in fact are responsible for 3/4 of the spending increase from 2014 to 2018. So that's concerning. And then Kaiser Family Foundation recently did some deeper research into this, and they found that private insurance rates for hospital services are 141 to 358% higher than Medicare rates. Now, 358%, Jim and I are not seeing that as we work with clients, across the board. We haven't seen a 400% increase over Medicare rates. However, there is obviously some room for improvement, and those are the things that we're going to be discussing today. One of the other things is that, if you consider really the underlying theory here for price transparency, it really is that our markets don't operate the right way. The healthcare pricing market, the buyers are not able to understand their pricing well enough to be able to make comparative decisions in an informed way. So that's really at the heart of the legislation, is to help buyers, not just consumers, but also payers and self-insured corporations become more informed and hopefully better shoppers. So this isn't our first foray into this price regulation, right? Obviously, the idea is not new. CMS has been evolving over time. In 2018, we were required to post our charge master rates. Hospitals were on their websites, and that did not result in much change in behavior because, as we all know, charge masters are very difficult to interpret alone. And so consumers were not able to get additional information. Neither were other buyers of healthcare. So this price transparency legislation of 2019 is the one that is now due, obviously past due as of January 1st. But it's not the only legislation either. There are 7 U.S. states, as listed on this chart here, that have done very similar types of price legislation, price revealing, price transparency efforts. The first of which was New Hampshire, 2007, 12, 13 years ago. And that website is available for all consumers, negotiated rates, revealed as bundled prices and also procedure prices. And then, as you can see, one of the more comprehensive solutions websites, because it shows those price comparisons by insurer, by medical group, by hospital, and even includes freestanding ambulatory surgery centers. So New Hampshire's one, but Colorado, Florida, Massachusetts, Maryland, and Washington all launched similar efforts in 2018. So for all these reasons, we don't believe this is a unicorn ask. This is something that is clearly not going to go away quickly. And then also important to consider is that payers are also being asked to put together machine readable files by the end of this year. So the effort is not just a one-off. Important for us to consider. So here we go. Ready or not, this new year brought the price transparency rule. And there's some teeth that CMS has put into it in several ways. One is the penalty of up to $300 a day for noncompliance. There's also this potential of a list that will be published of those who are noncompliant, published for the public and for the media. And then thirdly, there's some discussion about whether Medicare Advantage rates are going to be set or could be denied for those hospitals that do not comply. So lots of reasons for hospitals to consider complying if they haven't yet. Let's take a look at what that rule is. This should be pretty familiar with you, but the current legislation has two parts. One is the machine readable file, which a hospital has to post in that format all inpatient and outpatient items and services with a discounted cash price, every payer-specific negotiated rate for every item and service, and then as well as a de-identified minimum and max rate. This by far is the most complicated and challenging piece of the legislation. Possibly, in addition, the consumer-friendly format it reveals just 300 shoppable services, and 70 of those are mandated by CMS. And the information there that needs to be posted is the specific payer negotiated rate grouped with ancillaries. But when CMS changed the legislation they clarified, I suppose, a piece of that legislation that allowed you to use your existing price estimators. And we believe that has allowed a number of hospitals, it reduced a significant burden for them to consider purchasing or developing their own consumer-friendly format for those shoppable services. So what we'd like to know now, we'd like to go to a poll question. We'd like to get some feedback from you. Does your organization currently have a complete machine readable file posted online? And if not, we'd like to know what the biggest challenge is that you're facing. So here are 4 options for those of you who do not have a machine readable file posted online. Can you select one of the 4 that apply or more if there's more than one reason? Abby, I'm not seeing that folks are submitted, so I'm wondering if you could help them know what they need to do to participate in the poll.
Yeah, it looks like we actually do have some folks.
Yep. I'll do it now. Okay, good. Okay. Thank you all. For those of you who have submitted your answers, I'm going to hold until the end to reveal all those answers. And I have another question. So if you're ready to move on to question number 2, is your organization compliant with the consumer-friendly shoppable tool? If so, what type of tool is it? Is it an existing price estimator? Was it a tool you developed in-house or a tool from a third-party vendor? And I'm seeing your answers come in. Thank you very much. All right. We'll keep those open so you can answer as we move on. Jim, I'd like to transition now to you to go over some of the compliance analysis that we have done and the studies so far.
Great. Thank you. And thanks, everyone, for joining us today. So just wanted to go through, start off with a little bit of an informal survey that we completed within IBM Watson Health, looking at, sort of the compliance landscape, right? There's been a number of articles recently, even within the last week, talking about compliance in different markets and based on hospital size. So we went to do a little bit of an informal survey as well, given some of that information, and often questions that were asked a lot by hospitals that we talked to. So we looked at sort of the hospital health system landscape in New York City. And, we did de-identify the hospitals and systems on here and blurred them out. But I think the key takeaways here are sort of at the bottom right of your screen. So as it relates to the machine readable file compliance, only 2 of those 17 hospitals had a complete machine readable file on their website. The one thing that we don't know right from the prior questions is how many folks have it done, right, and are just sort of holding off on posting it for a variety of reasons, which we'll talk about. And then secondly, the second component, the price transparency solution, the consumer-facing tool, much better compliance, throughout New York City with that. And again, I think that has a lot to do with CMS allowing hospitals to use the existing price estimators that they were using, which certainly makes sense that CMS would allow for that to happen. But it does point to, the issue that many hospitals are facing is more so around pulling together the machine readable file and or feeling comfortable sharing those rates and posting that information online. So again, the conclusions here on the left, this really, I think, is reflective of the rest of the country. And I think that in your respective markets, this is what the rates is likely looking like, where there's more compliance on the tool portion of the final rule, but much less compliance on the publicly available machine file. So in just looking at this a little differently, right? So if we look at this as well from a sort of a hospital size, right? So tier 1 being your largest hospitals, tier 2 sort of we'll call mid-size, and tier 3 on the smaller size, but they're still pretty sizable hospitals given those entities. So in tier
Hey,
1,
Dave, or Jim.
Yes.
I'm going to stop you 1 sec. I'm getting a little bit of feedback real quick. Do you want to see if we can get a little bit closer to your microphone just to make sure we're
Sure.
getting your sound clearly? That would be great. Thank
Sure.
you.
Thanks, Abby. Sorry about that, everyone.
Perfect.
So if we look at those tier 1 or those larger hospitals, we saw, in this, informal study that 1/3 of them had compliance with the machine readable file. 100% were compliant with the tool, which again supports the continued use of existing price estimators. But as we moved a little further down the line, right, if we look at sort of those mid-size hospitals too, none of the hospitals were compliant with the machine readable file, but 2/3 were with the shopping tool. Again, highlighting the issues with the machine readable file, comfort of posting that information. And then the smaller hospitals look a little bit like the larger hospitals. So, mid-sized, mid-tier hospitals seem to be, at least in our informal study, challenged with this the most. We'll talk a little bit more as we move forward here around the machine readable file. As Betsy mentioned, we have a lot of experience in doing this.
I think, so sorry. Sorry, attendees. I think we still are having a little bit of audio issues with Jim. Just give us 1 moment and we'll try and get this resolved quickly for you. Let's see. In the meantime, while we get this resolved, attendees, make sure if you check out our resources and our survey, and we'll be back real shortly. Jim, do you want to do a quick audio test for me?
Yeah, I muted out and I can still hear the background noise, unfortunately. So hopefully it's a little bit better now.
I think so.
Okay. If that issue persists, I'll ask Betsy to sort of take it from there, please.
Sure.
So my apologies. So again, in the compliance analysis,
Okay.
I think we're still having issues, Jim.
We're
Betsy, if
still
you want to
having
go to
Sure. Sure. Let me talk here a little bit about our compliance analysis and what we found. And that is, as Jim said, pretty much the machine readable file is the hard part. We don't know if it's because it's too hard or because we've built it and we don't want to share it. But the work that we've done around the country has really informed us that this file is much more difficult to build than most thought. And so let's talk a little bit about what we've learned. First of all, part of it has to do with all the sources of data, where it all comes from, how it's all stored. We know that it is not because there's any intentional act necessarily to pull these, to not display or to try to hide something about the way prices are pulled. It's really much more about the fee schedules, the variety of them, the variety of plans, the fact that your charge master reflects some pieces, but things that are in the outpatient area, surgical, soft-coded surgical procedures, so forth, very complicated. Some things are bundled, some things are not bundled, and really when it comes down to an individual item or service, it can be very challenging to know how to display it in the files. In addition, many of our clients have upwards of 250 payer contracts, right? And that's a lot of file. That's a lot of columns in this machine readable file. As you know, that's a lot of cells to try to QA to make sure that everything is displaying correctly. So it has turned out to be quite an undertaking for the folks that we are working with, and we have a suspicion that that's what's really going on around the country as well. So what are the key lessons? It's more time-consuming than you expected. It's like the spaghetti junction of the interstate. There's a lot of variation, and there's a lot of carve-outs and things that apply and things that don't apply. It really does highlight some issues within current hospital charge masters. Oftentimes there's many duplicate prices. It's difficult to keep those charge masters updated. Sometimes new rates are just added. And then once all of those are added, sometimes it's also difficult to understand just the 300 shoppable services. Of those shoppable services, are all of them included? And should they all be included? There's a number of questions that come out as we are working with our clients, and some of them are technical and some of them are strategic, right? So we have to remember another question that has come up as we are building these machine readable files at this time of year. A lot of rates are coming in, Medicare new rates and insurance contracts. And we often get the question, should we use our 2021 rates or is it okay to use our 2020 rates? And our answer to that is to make sure that you focus on a snapshot, right? You're building a snapshot of those rates at a specific point in time. So if you've loaded everything as 2020, keep it 2020. And then the minimum requirements are that you have to update that once a year. So we did it in 2020. We can do it again in 2021. Let's talk a little bit more, though, about the strategic implications of this legislation. And IBM Watson Health conducts one of the largest consumer healthcare studies every year. And in that, we learn a lot about us as consumers. And one of the things that we've learned is that we as consumers still rely pretty heavily on, and we trust our doctor's recommendations for treatments, especially when that has to do with something that's exceeded our out-of-pocket estimate. So when we're considering something that's a very expensive treatment, we do not only rely on price, right? Because we know we're already going to meet even if we have a high deductible plan, we're likely to exceed that, and then we become less price sensitive. And it's also difficult. We use a lot of other factors. We want to evaluate quality of our physicians. However, we find that difficult. And in some cases, we also have patients who think that higher prices equals higher quality, right? So using price alone as an indicator or a shoppable piece, price is a little bit important to consumers, but it's not the only thing, right? It becomes much more complicated. And we think it's very important that when you think about what the impact of this legislation is going to be, if we're only displaying price, probably not going to have a big impact. If you think about other factors and add in some of those additional factors as you build out your services to communicate with your consumers, you'll want to make sure that you think about things like accessibility, availability, and quality when you're adding those into the tool. So remember when we talked about New Hampshire and their website that started in 2007? One of the things we learned, many have studied that to understand what was the impact on consumers of that website. And what they found over time was it wasn't great, right? Only about 8% of the folks who could use it actually did use it. And when they did, they primarily shopped for imaging services and labs. So as a result, the impact on consumers, even after there was quite a bit of marketing, some specific campaigns run in the state to try to encourage people to use this tool that's available to them, it really didn't generate a whole lot of interest or activity. So for those reasons, we don't believe that there's going to be a big impact on consumers. However, it doesn't necessarily mean that this effort is not worth it, because I think we all can understand that healthcare pricing is confusing, right? It's even confusing for us who are in the industry. Some of us who even do reimbursement for a living, we have a hard time telling a patient specifically what the cost of a procedure is going to be before they have it. And so remembering that our consumers experience healthcare in an episode, right? And I need to go have my knee replaced, not procedure codes, right? But insurance bills by procedure code. There's a bit of conflict here, right? That we all are aware of, and it's not perfect. And so we know that there's really an opportunity here for us to make this better. And so some some pundits have said maybe this process of going through this painful process of developing these machine readable files, maybe in some way will help shed some light on the fact that reform is needed, that we do need to price in a way that is easier for our buyers to understand. And so that's kind of the hope, I guess, is that there will be in the future some ability to do some reform. And it is actually an interesting thought within your particular market, especially if you're in a competitive market. There's an opportunity for hospitals who will become that very transparent place to go, and that they're committed to trying to make their pricing more easy to understand. And if you look at even payers following the same suit, there's Oscar Health, still to be determined how well it's going to work, but their entire strategy is really to try to make the whole process of buying insurance easier to understand. So then once we pass, okay, not much on the consumer, what do we think is going to happen with prices? especially given that we believe that some are holding on to their machine-readable files with a bit of reluctance to release them, particularly in competitive markets. But when you step back and look at the national statistics, 70% of our hospital markets in the U.S. are so consolidated that they lack effective competition. So I think that adds to the complexity of this type of pricing reform, right? If you know that there aren't a lot of alternatives, why are you going to shop, especially for the really expensive pieces of your care? And when we look back at New Hampshire again, that study that we took of what happened in New Hampshire over the past 12 years, what we found is rates did not drop across the board. Specifically, there was a 1% to 2% drop in imaging costs. And then in terms of total overall spend, a 3% drop in the state overall spend. That was primarily due to the imaging cost. So once again, it's important to think about, where do we think that the price impact is going to be? If you think about it from a consumer standpoint, it's definitely going to be in those services that someone pays out of pocket for, imaging and labs, not the large inpatient services that account for so much of your hospital revenue. So yes, will it impact prices? Perhaps. Will it have a big impact on that? That's still to be determined. Another study was that if you looked at the 70 mandatory CMS shoppable services, those collectively only represent about 17% of an average hospital's revenue. So really, will there be an impact on prices in those areas? Perhaps. What does it look like based on the evidence that we have so far? It's probably not going to be hugely substantial. However, importantly, if you are in a competitive market, you do need to understand. You do need to understand how do your rates compare, and particularly when you're thinking about those payer conversations, what do you know about your market? How do you stack up? How are you on the expensive side? Are you on the less expensive side? And also talk about quality and those other factors that are important to our payers. So in summary, machine readable files, our recommendation is go ahead and do them if you haven't done them. Yes, they're complicated. Yes, it's to some degree, but we don't believe that it's worth the risk of being added to that public list of non-compliant hospitals. And also taken in conjunction with the fact that your payers are creating those same machine readable files and having to get ready to display those by the end of this year, it makes it even a very short time window right now of risk, I should say, right? Because those rates are going to be revealed anyway. So if the factor is there's some risk of having your name be on some sort of non-compliant list, probably not worth that effort. But of course, it's your decision as a hospital. If the issue with the machine readable files is that they're complicated, there's many firms that can, help you and focus on that, because we know there's a lot of other conflicting, important issues, such as this pandemic that you happen to be working on right now. Secondly, consumers shop when they have to pay for their out-of-pocket. So if you're going to think about your strategic pricing, the first place you probably want to focus on are imaging and lab. It's important for you to know, as I've already said, how your rates and how your quality compares. You really need to be prepared to explain that to all of your buyers, right? To the consumers, not only, but also to payers. And then our recommendation about the shoppable tool is you begin to think and make an investment in a tool that is a foundation for many more ways to interact with your consumers and for patient engagement in the future, making sure that you can add additional factors that we know that consumers use when they're shopping for tools. So let's take a look at what you said in terms of whether or not you are compliant today. And if you're not, why not? So 31% of you said you don't have the time or the resources right now, not surprisingly with everything else that's going on. 41%, however, said that it is completed and you don't want to post it yet. Interesting. 14%, we do not want to disclose our pricing and we'd rather pay the fine. I put those together. I think that maybe clarifies why you don't want to post it yet. And then the difficulty to create that, 16% said that, and that probably also sort of relates to we don't have the time or the resources. So thank you for that feedback. Let's take a look at the other one around compliance with the consumer-friendly shoppable tool. 23.6% of you said you have an existing price estimator. 26% said that you use a tool that you developed in-house. And then a little more than 50% of you purchase a tool from a third-party vendor, which may be your existing price estimator as well. So very interesting. Thank you all for participating in the poll. We'd like to now shift to your questions.
Excellent. Thank you so much, Betsy. And I believe we've got Jim back for this Q&A portion. So we'll now begin today's question and answer session. As a reminder, you can submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll get through as many of these as we can. So the first one we'll take here, the attendee asks, if the rule states the data has to be easily accessible and not requiring a login or entering PHI, how are some hospitals getting away with requiring users to enter name, date of birth, and other subscriber information?
Do you want to take that one, Jim? Are you able
Sure.
to?
Yeah, can you hear me?
Mm-hmm.
Perfect. So sorry, everyone. Thank you. Yeah, it's a great question, right? And I think what CMS clarified towards the end of 2020 in sort of greenlighting the allowance of existing price estimators, there's an understanding and a statement, certainly about those price estimators requiring what amounts to PHI, right, to generate that estimate, which sort of goes against what they talked about the requirements were for the consumer-facing tool. So they've created a little bit of a gray area, but I think from our perspective and what they've clarified later in 2020 is that even though those existing price estimators do require in many cases, PHI to generate an estimate, they're still considering them to be compliant. I do think the one key point, about those existing price estimators is that it has to generate an estimate at that point in time for the consumer, right? So it can't be an estimator tool that requires, certainly, the billing office to follow up in an hour or a day or something like that. So it has to be something the consumer can interface with and use and generate an estimate from at that time, even if it requires PHI. I think the important piece there as well is to make sure that if you are using an existing price estimator, and while it should be providing estimates for much more than 300 shoppable services, it certainly needs to include the 70 mandatory that CMS has prescribed as well. So that would be one check. And if it's not there, then you would want to talk to your partner or your vendor in that regard and make sure that that's on their roadmap fairly quickly to be added from a compliance standpoint.
Thank you for that added clarity there, Jim. The next question we'll take is the attendee asks, what is expected on enforcement from CMS?
Well, I mean, there was a call that they scheduled back on December the 8th, right? I think that got a lot of people's attention, more so from the timing of it, right? So for folks that were holding out hope that the rule was going to get pushed back or implementation was going to get pushed back. That did not occur. They took that opportunity, I guess for those of you that weren't on that call, to share what they can do from an enforcement standpoint, right? So they have the, I guess, liberty maybe of giving you sort of a 30-day action plan to get it corrected. But they also said that they could start fining you immediately too if they found you to not be compliant. So they sort of opened the door of maybe trying to convey a little bit more teeth to hospitals, right, for noncompliance. As far as their enforcement efforts go, they did release something last week through a national publication that pretty much told the industry that we're looking, right? We're looking, we see that the majority of hospitals are not compliant in most markets. So they're slowly dipping their toes in the water. We haven't seen anything publicly released about actual enforcement, actual fines, but they're certainly sending, some messages through some key press members that they're looking and they see the amount of noncompliance that's out there. Anything to add to that, Betsy?
Yes, I was just going to say, I think that was a Becker's session or an article that they interviewed CMS to understand a little bit better. But CMS also said that they have released an online tool where consumers can file a notice of a non-compliant hospital. So
important points there.
Yeah. Go ahead.
Yeah, just important things to share with our listeners. Appreciate both of you weighing in there. This next attendee question is asking for, I think, some clarification around a statistic that was cited during the presentation. So the attendee asked, did you say 17 or 70% of the revenue for the CMS mandated services?
17%, 17%.
Great. Appreciate you giving some clarity to that number there. And I'm going to dig through and find another question for us.
And while you're doing that, when you do get the slides, the references where that data came from are at the bottom of the slide. So you can, if you're interested in reading more about those statistics, where they came from.
Great. Excellent. And yeah, just to clarify also, every question we haven't been able to get to, a member of the IBM team will reach out to everyone that's asked the question and contact you. Betsy, Jim, do you have any closing thoughts you'd like to share with attendees before we sign off?
I just really like to thank everyone for joining. It's obviously a really important topic, and as we said, it's not likely that it's going to go away. I'm not sure that we've found the perfect solution, right, to reducing healthcare spending or to doing pricing reform, but I think it is a start, and it's certainly a very significant step forward, I would say, or continue to push forward to and challenge to our industry.
Yeah, I would just add to that, right? I think it's a step in the right direction, right? But I think for all of those listeners that are on here that have spent a lot of time within your respective hospitals and organizations trying to figure out how you're going to meet the compliance thresholds, there are imperfections to this, right? And I think some of those were highlighted earlier by Betsy, and certainly have seen with some of the questions coming through around contracted rates, right, versus what a patient's actually responsible for out of pocket, or what the hospital actually gets paid. So it's a step in the right direction. It's not perfect, and I think from our end, knowing that a lot of folks out there are waiting to see what CMS is going to do from an enforcement standpoint, I think our thoughts are, we don't recommend waiting until that happens to have yourself ready to go in compliance. Now, whether or not you're comfortable with posting your MRF online, that's really a strategic decision, right, for the hospital and your market. But I wouldn't wait until CMS, notices that you don't have it up to start down that road. Because you'll find that even if it's a 30-day window, that's a tight window depending on the size of your hospital and the number of contracts that you have.
Well, appreciate you both sharing those in, and we've had just a ton of great questions come in. So I think we can actually go back on what I said and not close out just now. I'd love to ask this question from an attendee. They ask, based on the CMS rule about the machine-readable file, are you finding that where it states payer-specific negotiated charge line, could you use one median payer for this instead of listing all payer contract rates? The language seems differentiated on whether it is one or all payers.
It's a great question and one that we come across often, right? And the answer is not going to be to that person's liking, right? So the answer is that it's for all plans under each payer, right? So it's not a payer median rate. So if you have, 5 different Blue Cross contracts with 5 different contracted rates, then you'd have to have 5 different columns for Blue Cross in your machine readable file versus just one. So some of the partial compliance that we've seen in our informal study, particularly around the machine readable file portion, are hospitals putting a subset of payers, right? Not putting all of their payers. So dipping their toe in the water, right, with sharing information publicly and partially complying with that. But unfortunately, from all of the CMS releases, language, calls, it definitely is consistent with hospitals having to put down or include each of their individual plans versus just putting it at a payer level for the machine readable file. Wish I had a better answer, sorry.
Jim, appreciate you tackling that one. We've just had a ton of great questions come in. I think that's just indicative of how important this topic is and, how much is not really widely known. So the next question we're going to ask is, are there any considerations to outsourcing the creation of these pricing machine readable files, or is it preferable to keep it in-house?
I think that it's probably from a labor standpoint, from what we've seen in our experience, unless you are a large health system with a lot of resources, that have the capacity to do this and not focus on, COVID relief and recovery efforts, probably outsourcing is a good way to go. It's just going to be a matter of pulling the information for whomever that partner is for you guys. I think any vendor that partners with the hospital, there's going to be protections of that data, right, written into the contract. So it's not a matter of that vendor using your contracted information and rates to share with somebody else. But CMS estimated that there'd be about $12,000 in cost for a hospital to comply with this rule, and we've certainly found that is grossly underestimated. And for those of you on this call that have gone down the path of doing it yourselves or trying to do it yourselves, I'm sure you have seen that as well. So I think, it is a hospital by hospital decision, but from a labor resources standpoint, it's likely going to be easier to outsource that component.
Thank you for tackling that one. Go ahead, Betsy.
Yeah, I'm just going to add one little piece onto that, and that is that certainly when you think about it, the value also of outsourcing, not only does it, relieve your own internal folks of the burden of that and the distraction, there's also a real value to an organization who has done it multiple times and not trying to figure it out step by step, because there's a lot more efficiency in doing it multiple times, right? There's a lot of lessons learned through that process, and the more familiarity an organization has with your state's Medicaid policies and your Medicare in particular, just Medicare payment rules overall, that's going to help speed the creation of that machine readable file.
Thank you, Betsy. Thank you both for weighing in on that one. The next question I'll throw out there is the attendee asks, how accurate is the price information shown on different state sites? Does CMS have a plan to scrutinize the consistency on the listed costs?
That's a great question.
Go ahead, Betsy. Why don't you run with it first? I'll hop in there.
I just think that's a great question and an interesting one, right? Because CMS has not said that they would actually do anything to validate the accuracy of the numbers that are reported in the machine readable file, but they have made it very clear that they will, the compliance is based on the presence of a machine readable file. That is
I think if we take a step back right to the earlier question about enforcement. So one thing that CMS has stated really since the beginning of this announcement back in November of 19 is to say, from an enforcement standpoint, when those questions have come up, that they're going to be reliant upon consumer feedback, consumer complaints, right? So if the consumer can't find the price or can't find what they're looking for on your website, they complain to CMS, then maybe that gets them looking into things. I think in our perspective, right, we try to remind folks that since this is a one-time-a-year requirement, right, that you're putting your best faith effort forward to reflect your rates at a point in time, right? Because, and most of that for folks are going to be like the fourth quarter of 2020 rates. You're going to have contracts that renegotiate throughout the course of this calendar year. You are not required to update your machine readable file every time one of your rates changes. That would be, at least CMS isn't requiring that. So it's a one-time-a-year update. So it's going to be a snapshot and reflective of the point in time that it was done in that calendar year, right? And I think from a CMS perspective, that's what they expect. I think that's the guidelines that they've laid out there as well. So as long as you're taking that sort of good faith effort, that snapshot in time, I don't foresee there being an issue with CMS questioning the rate that you have up. So
no, actually, where that
piece.
Yeah, and where the accuracy does come into play, I think, Jim, you made a good point. The accuracy does come into play when you are displaying that to your consumers, to your patients, right, in the shoppable tool. So as you know, you do not want to be giving inaccurate rates to those who are buying your services. Not only because they may or may not choose you because of that, as we know, but also the difficulty within your billing office when a patient comes to you with a price that they thought that they were paying and the bill comes to be very different, right? So those are not good incidents, especially if it's an underestimate for you from a public relations standpoint with your consumers.
Thank you both for addressing that. I mean, we've got just a ton of great questions here. So the next one I'll throw out there, the attendee asks, what are your thoughts on how the language states charge rate versus negotiated rate that is used to list the CDM price versus the contract rate?
So that's a great question, right? So, sort of our interpretation of this, right, is for the payer-specific rates, right? So for the plan-specific rates, you're having to use the negotiated contracted rate in the machine-readable file. As it relates to your gross charge, that's going to come through from your charge master, right? For the items that Betsy referenced earlier that have to get added, to the MRF that aren't on your charge master, like DRGs, any of those outpatient procedures that are part of the 300 shoppable services that are soft-coded by your hospital's HIM department, you'd have to have gross charges added for them as well. So it's a little bit of both, right? We're taking the gross charges from the charge master. You're using your discounted cash price methodology across the board, whether that's for both inpatient and outpatient, or if you have separate ones for inpatient and outpatient. And then you're using the contracted negotiated contracted rates for each of the plan-specific rates in the machine readable file.
Thank you, Jim. Appreciate the added clarity there. And the next question will take the attendee as you mentioned that other provider groups will need to comply with pricing transparency. Does this include independent physicians as well as ASCs and other agencies, home health care, et cetera?
The legislation does not cover those folks at this time. However, I think by the end of the year, when payers reveal their negotiated rates for their in-network providers, I believe then all of those groups that you mentioned would be included in the, sort of the revealing of those negotiated rates, as long as they are in-network participants within a payer's networks plans.
Yeah, this regulation is very specific to hospitals and not other entities like independent physicians or home health. But, you know, it's probably not far on the horizon down the road, but this is just specific to hospitals.
Thank you, Jim and Betsy. The next question we'll take here is the attendee asks, do you recommend reviewing the raw negotiated payer contract to determine negotiated rates, or is using the actual payment from EDI data sufficient? Do you believe the EDI data is a reliable source for negotiated rates?
I think, so our interpretation of this, right, is we've been using the contracted rate and recommending for hospitals use the contracted rate from the physical contract. Again, that's how we've interpreted sort of the negotiated rate portion of it. We have had a number of conversations differentiating between sort of what a hospital's rate is versus what they get paid. So I think that really is sort of a hospital by hospital decision. I think to Betsy's point earlier, it's, you know, what are you most comfortable with conveying to the consumer, particularly around these 300 shoppable services, right? So, you know, you want to have that in mind when you're making that decision. You know, our push has been more towards the negotiated contracted rate, but we have had hospitals, you know, push back a little bit and maybe have a little bit more interest in you know, posting what they're getting paid for each of the procedures.
Thank you, Jim. Again, just great questions coming in, a ton of them. If we're unable to get to any of your questions, again, an IBM team member can help. I believe we shared some information on how you can reach out and engage with those folks. So I think we're right at the top of the hour here. It's been a wonderful conversation. Jim and Betsy, thank you so much for taking all those questions and sharing all these important insights with our attendees today. I know they appreciate it. So thanks again, Betsy and Jim.
Thank you.
Thank you.
I'd also like to thank IBM Watson Health for sponsoring today's webinar. For more information on today's content, please check out the additional resources on your webinar console, and don't forget to fill out our webinar survey. Thank you for joining us today. We hope you have a wonderful afternoon.